Hello, my name is Craig Senholzi. I am the Medication Safety Coordinator at Thomas Jefferson University Hospital, and I will be discussing briefly our project that's entitled Reducing the Number of Missed Doses for Venous Thromboembolism Prophylaxis. And I also want to acknowledge, as you can see on the screen, other members of our team who have an important role in the success of this project. This project came about as a result of concern over the occurrence of VTE, of venous thromboembolism. I'll use VTE during this talk, during or shortly after hospitalization. And we identified missed VTE prophylaxis doses as one possible contributing factor to the occurrence of the VTE. We identified that in the literature shows that missed VTE doses occur at an incidence of 10.9 to 13.6% of doses in hospitalized patients. So we did an initial audit of our doses, scheduled doses of VTE prophylaxis, and we found that 7.03% of our doses were omitted for one reason or another, mostly because patients were refusing the doses. So our hospital administration was very concerned with this data, and we undertook an effort with the goal of reducing our rate of missed VTE prophylaxis doses. So this project started in November of 2018, where we conducted a survey of our nursing staff to get their understanding, to assess their understanding of VTE and the use of mechanical and chemical DVT prophylaxis. Based on those findings, we then developed an educational program for the nursing staff on the topic of VTE. We also started unit-based focus groups that met with the nurses at the bedside to find out what barriers there were to administering these medications. We undertook a number of interventions, as you can see in the middle column on the poster, to try to reduce those number of doses. And we had a mandatory VTE prevention module on our intranet. We did multiple presentations to a variety of groups that would be involved in this process, including nursing, physicians, and pharmacists. We presented this to also. We standardized our VTE prophylaxis times. We developed an escalation process for notifying first the nurse manager, and then if there are additional missed doses, going up to the house staff, and then ultimately to the attending physician to get their involvement in this process in trying to help the patient understand the importance of receiving their doses and not refusing them. We develop patient education materials that we provide to the patients. We also distribute this in our pre-admission testing area to the patients so that they have an understanding before they get to the hospital of the importance of this process. We develop scripting for our nurses to help them know what to say to a patient when they're refusing doses. We approved that pharmacists could retime doses to try to avoid giving doses in the middle of the night, because we were seeing patients were refusing doses because they didn't want to be awakened during the course of the night. As you can see then, our results after we made these changes, we significantly reduced our refusal rate to 4.8%. That was statistically significant, so we were very happy with that. I think the key factors in our project's success was that it was a very multidisciplinary effort involving, again, physician leadership, nursing leadership, the nursing staff, pharmacy, performance improvement, and patient safety, as well as with hospital administration overseeing this process. And they had a very vested interest in reducing the occurrence of VTE in our patients. Since we've started this, we have seen our results have been, we continue to monitor this on an ongoing basis. Our results are pretty much around the 5% performance. So we haven't changed much since that initial month. What we have done recently is, because most of these VTE doses are injectables, either heparin or Lovenox, we have recently approved through our P&T committee to start to use rivaroxaban, an oral anticoagulant, in our medical patients. So that process will be starting soon. We hope that that will further reduce our occurrence of missed doses. As far as replicating this at other hospitals, I think that this is a very low-cost initiative. Most of the expense here was just in individuals' time, in our education of our staff, in our development of patient education materials, and in developing our escalation process for notifying, as I said, nursing managers and then up through the attending physician. So not much cost other than that in developing the process. We continue to hope that we can keep that rate low and even go lower with our expansion of oral anticoagulants to help us in this process. And I will also mention we provide weekly data to our nurse managers on the performance on their individual units so that they can address that with their staff and try to identify if there's alternative anticoagulation that we can use in a patient who continues to refuse the injections.